Dr. Anusha Mohan.
Yashoda Mohan.
Welcome to today's episode.
Thank you, Grant.
Yeah. So for those that may not know, a good doctor here, she's a neuroscientist with a background of biomedical engineering. And over the few, I don't know, many years, she's worked in research in tinnitus and dementia. So maybe my opening question to you is why biomedical engineering and moving to do tinnitus and later on working in the dementia space?
Well, thank you, Grant, first of all, for having me here. I think it's a very exciting opportunity to have this conversation with you. Why biomedical engineering? Well, I didn't want to become a doctor. And when we were in school, it was the whole system that you could either go become a doctor or you can become an engineer. But somehow I was always fascinated with biology. I was fascinated with the human body, the heart, the brain. And I also wanted to study engineering. So initially I wanted to become a biotechnology engineer, which I think I would have royally failed because I really don't like biochemistry. And so I think it was only after I joined in biomedical engineering circumstances. So I was like, okay, this biomedical engineering was really up and coming when I started. It sounded very novel, and I was quite interested. And it's only when I started biomedical engineering that I realized that if I had done biotechnology, I would have failed very much. And I quite discovered my interest in brain activity in EG specifically, which is the recording of electrical signals in the brain. And I pursued that in my undergrad, and I went on to pursue the same thing in my master's and in my PhD. So although I think from a CV perspective, it seems like I had moved from engineering to audiology to psychology to medicine, the thread, the sort of the string that threaded all the beads was EEG and my interest in understanding how the brain works with respect to when you play sounds, when you hear something, when you see something. And that's sort of the passing line.
So because I think before you became an Atlantic Fellow, your focus was on audiology, tinnitus. Is it because when you joined the fellowship, you found more people that are so dementia focused, or maybe there was a link between tinnitus and dementia or any type of?
Yeah, I mean, when I started or before the fellowship, one of the things that, I mean, it's the same thing with biomedical engineering as well. The tinnitus is it's a topic that found me. And when I was doing my master's, I was doing a project where I was trying to understand how the brain processes sounds. And I was very fascinated by this concept where people are hearing something, but it's not really there in the environment. Initially, I thought it was, a hallucination, but it's not really. It is a hallucination, but it's not accompanied by delusions. And it's an everyday phenomenon in the sense that, sometimes when we walk out of a loud concert, even, us have had the experience of tinnitus in our day-to-day lives as well. It's something that comes and goes. It's this ringing in the ear, or some people hear a buzzing, and then it goes away. I get it when I'm extremely stressed. A lot of people get it either in the morning or in the evening. And quite a few women have also reported that sometimes they have a perception of this ringing sound, depending upon where they are in their monthly cycles, postmenopausal, postnatal as well. There's quite interesting avenues in which people perceive tinnitus. And so that's sort of what I got hooked on to when I was doing my PhD, and this combined interest of trying to understand what is going on in the brain. And the more I studied it, the more I realized that the brain is very much involved in generating tinnitus, especially in people where there's no sound source, there's no external or even internal sound source. For example, some people can also have tinnitus when they have their auditory nerve and the blood vessel impinging on each other. So sometimes that's called a very objective tinnitus. But in people who have chronic subjective tinnitus, there's no source for the sound, but still they hear this constant sound. So that was sort of the fascination. The link with cognitive problems or particularly with dementia, comes from one, hearing loss is a major risk factor for tinnitus, and almost 80 to 90% of people with tinnitus present with some sort of auditory problems. Either they have severe hearing loss. And the common sort of profile is an older person with severe hearing, moderate to severe hearing loss in 1 year or both ears. And they have this constant ringing sound. And initially, it was thought that it was, again, very similar to dementia. It was thought that it was an older person problem. But now we see that more and more there are people who are younger who get tinnitus as well. Stress is a very important factor as well in generation of tinnitus. A lot of people have reported that their tinnitus has started when there was a very stressful event. So as you can see, and you can start to see the relationship between cognitive problems and tinnitus. And one of the biggest things that, from a cognitive perspective, is affected in tinnitus is attention. So people complain that they're not able to focus on their everyday activities. They find going to work very hard. They find focusing on things very hard. So there's definitely attention problems. A lot of people also have other kinds of sensory problems in the sense that they have this sensitivity to sound, which they call hyperacusis. So it's normal sounds can be quite painful in a normal volume. It's not that it has to be very loud. So there's also other sensory problems. And of course, from when you look at tinnitus from a brain perspective, you see that auditory regions, of course, the auditory cortex is involved, but also medial temporal regions like the peripacampus and hippocampus are also involved when people have severe tinnitus. So you can start to see the links with dementia, the links with cognitive problems. Well, it's still under discussion whether tinnitus is a risk factor for dementia. We don't know that. And that is what my pilot is also looking at.
But we know hearing losses.
We know hearing loss is a very big risk factor for dementia. And so it's still under discussion whether it is the tinnitus itself, because there are some studies which on the very non-intuitively says there are some studies that show that tinnitus might make the system a little bit better. Is it neuroprotective? I think that's a little bit of a stretch. Of course, when you talk to people who have very severe tinnitus and they're suffering from it, it's hard to believe that it could be neuroprotective. But there are some models that show that when you have noise in a sensory system, it can improve perception a little bit. And you see that in the visual system all the time. So it's not very clear what the relationship between tinnitus and dementia is directly, but definitely they share common risk factors like hearing loss and stress, and of course attention problems, and there are cognitive disabilities in both. So this is quite a hot topic ongoing as well, and sort of my link between the two worlds.
For you to do more studies and more research in the area, then you found yourself in dementia, specifically in Lewy body type of dementia. So maybe how would you explain the difference between dementia and Lewy body dementia?
That's a great question, and I think I get asked this question quite a lot. Well, how I found myself in Lewy body dementia is also quite serendipitous, and I am immensely grateful for serendipity to have worked out that way. The difference between dementia and Lewy body dementia is that dementia is an umbrella term, and it's an umbrella term which consists of different kinds of dementia. For example, Alzheimer's dementia is one kind of dementia. Vascular dementia is another kind of dementia. Lewy body dementia, that way, is another kind of dementia. So it's a subcategory of dementia, which is the umbrella term. And Lewy body dementia specifically is different from Alzheimer's dementia and other kinds of dementia in certain ways.
How common is, maybe before we go to how common it is. So I know when you differentiate these, how are we defining what Lewy body dementia is? Like, is there anything in particular happening in the brain?
Absolutely. So Lewy bodies are these protein deficits. It's very similar to Alzheimer's disease in the sense that, not very similar to Alzheimer's disease, but in Alzheimer's disease we have beta amyloid plaques and tau tangles, and they are made of a certain protein. Lewy bodies are made of a protein called alpha-synuclein, and alpha-synuclein deposits in the brain. It could deposit in the brain, and when it deposits in different parts of the brain, you have different symptoms. And sometimes it can start in the brain, it can deposit in the body. So depending upon where these alpha-synuclein bodies or Lewy bodies deposit, and it can affect different symptoms. And that's why it's called Lewy body dementia, because it's a different protein.
Yeah. So what causes the accumulation of alpha-synuclein?
I don't think I'm the expert of that. but I can tell you what happens after the
Mm.
deposition.
Mhm.
What causes the deposition, I am not the expert.
Mm.
But once these deposits are found, usually the difference in the symptoms between, for example, Alzheimer's dementia and Lewy body dementia, the main thing is in which cognitive domains are affected. Usually in Alzheimer's pathology, you see that they deposit in your hippocampal, parahippocampal regions, affecting memory. In Lewy body dementia, they start from globus pallidus and in the basal ganglia itself. And so they start as a decrease in dopaminergic, they start as degeneration of dopaminergic neurons. So they could, depending upon where they get, which regions they affect, they can either start off looking like Parkinson's disease. So they can start with motor symptoms. And a lot of people with Parkinson's disease, it's said that about 80%, 50 to 80% of them have a risk of converting into dementia. When they start presenting with cognitive problems, that's when we start to add the term dementia. Until then, we don't really talk about it as dementia. Because with Parkinson's disease, there is still formation of Lewy bodies. There's still what we would call synucleopathies, which means that it's the same protein deposition. But in Parkinson's disease, people usually don't present with cognitive problems, and they usually present with motor problems like rigidity and inability to initiate movements. And so people with Lewy body dementia, or people who start with dementia, so the other side of it is called dementia with Lewy bodies. And dementia with Lewy bodies starts with cognitive problems. So either they can start as problems with hallucinations. So a lot of people start with delusions and very vivid visual hallucinations. Some people can start with executive functioning. Problems with executive functioning is reported quite a bit, especially planning and execution of tasks. A lot of people also present with loss of smell, almost even not just when the dementia starts, not just when the cognitive problem starts, but many, many years even before the cognitive problems can onset, people have a loss of smell as well. So we're also looking at not just sort of a linear trajectory, if you may. So with Alzheimer's, it's still, I wouldn't minimize Alzheimer's to say it's a linear trajectory, but it's quite a consistent trajectory of having memory impairment. With dementia, with Lewy body dementia, it could either start with hallucinations, or it can start with executive functioning, or it can start from the body in the sense that it could start with falls and fluctuations in blood pressure. A lot of people, and one of the most common cognitive symptoms that's reported is fluctuations in cognition. And one of the main differences between Alzheimer's dementia and Lewy body dementia is that in Alzheimer's dementia, you often hear that people forget who they are, people forget who you are. So there's quite a loss of identity and a loss of cognizance in the person itself. But in Lewy body dementia, it's not very frequently reported. Memory problems, although can occur later when the disease is quite advanced, people are still, especially care partners and families, report that they know that the person is still there. So they're quite present. And there's this lucidity that the cognition comes in and out, but they very much know who you are, who they are. They know, for the most part, they know where they are, but the main thing that is lost is communication and speech. So they know who they are, they know who you are, but they're unable to communicate with you.
So I know you've talked about how Lewy body is different from Alzheimer's disease in terms of presentation. Is there anything in particular that, as a young person, I would want to be aware of, that maybe if I'm having lack of sense of smell, hearing, what's the one thing maybe you would? I know the presentation might not be like, it's not across the board. Everyone has to present the same. But what are the common presentations that people need to be aware of?
I don't want to scare anybody, because especially with COVID, we've had a lot of loss of smell. We have, we can, and I think that has been one of the sort of, biggest scare points. Oh my God. So if I get COVID and if I've lost my smell, am I at a higher risk of developing Lewy body dementia? No, I don't think I don't want to scare people that. But I'm also learning about Lewy body dementia, and I'm quite new to the field as well. But from my understanding, it comes back to the same question of brain health. It comes back to, there's increased risk of this. I think the question you asked was what causes these depositions of Lewy bodies. We hear the same thing over and over. Cardiovascular risk is a big one for Lewy body dementia. Previous case of depression and previous cases of, a history of mental illness. It's very similar. It's the same kinds of things that you hear for any kind of dementia. And so I think for a young person, I think it is important to eat well, sleep well, and have a healthy lifestyle. And that seems to be the most important thing. But in terms of symptoms to look out for, what people have reported is a loss of executive functioning. Seems to be, it's something that you pick up on very quickly. You pick up on it very easily. It's quite a change in, it's quite a change in personality as well, that somebody who's able to plan and execute things are having difficulty. So I think that would be one of the signs to sort of look out for. And also, if people are having trouble with, especially the vivid visual hallucinations, is another piece. And the other piece that we haven't talked about is also what they would call REM sleep behavior disorder, which means that people are kicking in their sleep and acting out their dreams. So that would also be something, be not the person, or they're falling off their bed, for example. So things that they might not know, but if there's a partner who's sleeping next to them, might pick up on. And so again, just because you have these symptoms, does it mean that they have dementia? That is where, that's where it gets tricky. Because just because somebody is having hallucinations, does it mean that they're having dementia? Probably not. And that's where the differential diagnosis of whether this is a psychiatric problem or whether this is a problem of dementia comes in. And that's why the sort of multi-system approach of looking at neuropsychiatric symptoms, looking at their gait, looking at their cardiovascular health, looking at their cognition. So all of these things combined with an MRI and what you would call a DAT scan. And a DAT scan is something that takes a picture of how much dopamine is consumed in different parts of the brain. So all of this together with the scans would be your sort of ultimate diagnosis point.
I was almost getting scared when you're talking about healthy sleep, and because I have a lot of lucid dreams. I'm aware that I'm dreaming stuff.
Lucid dreaming is different.
Yeah, so I was hoping you don't mention something like that.
No, lucid dreaming is different. We're talking about, I think, I've heard a lot of people have lucid dreams, and lucid dreaming is very different. We're talking about people who kick in their sleep, a little bit like narcolepsy. And that's a very different kind of disorder than lucid dreaming.
Okay. Yeah. So how common would you say Lewy body is? Because if I go on Google and Google common types of dementia, it ranks about third place. So with the advancement in research that's happening now, how accurate is that information?
Yeah, I think that's about right. I think 10 to 15% is the predicted number, but the number of cases that are diagnosed correctly and accurately are very less, especially I think if you take the numbers in the UK, then I think the numbers are somewhere at less than 5% are accurately diagnosed or something like that. So it's a very small number that's diagnosed. And definitely it's very popularly known as the most common form of dementia that nobody has heard of. So if you talk to, when you talk to people, they're quite aware of Alzheimer's dementia. They're very aware of Parkinson's disease, and they know they can identify the presentations of Parkinson's disease with the tremor and the gait problems. But when you ask them about, do you know Lewy body dementia, most people say, oh no, I've never heard about this.
Yeah, and I think it's because maybe there've been a lot of investments in Alzheimer's disease, its research and treatments, because I think it's the only type of dementia that has got a disease modifying therapy.
Yes, disease.
Yeah. So is there like a specific, because I know with Alzheimer's disease, it's mostly common in people that 60 and above. There might be young onsets, maybe 45, 55. What's like the age?
So with Lewy body dementia, my understanding is also that it's mostly it's common amongst older people, but the young onset for Lewy bodies is also quite common.
Yeah.
Because now we know that there's more and more this increased number of cases with young onset Parkinson's disease. And although there's still quite the discussion between Parkinson's disease and Parkinson's disease dementia, which with the PDD dementia component would come under Lewy body dementia. But Parkinson's disease itself, whether there's still discussions going on as to whether that is, is it the preface of the dementia itself? Because there seems to be a good, 7 to 10, 15 years between, or even more, between the onset of Parkinson's disease and the onset of dementia. So if you think about it from a Lewy body disease perspective, because Parkinson's disease is also a Lewy body disease. It's not a dementia, but it is the same, protein, same deposition, same Lewy bodies. So with Parkinson's, yes, you definitely have young onset Parkinson's. But with the dementia phase, it's still mostly common in older people, but we are seeing cases of cognitive problems and psychiatric problems starting on much sooner. There are a few people that I have met whose partners have started as young as 45, or they were diagnosed at 50. So yeah, it's not uncommon.
What's like the progression rate? Like, is there like some assumed time frame as to when someone may progress from mild cognitive impairment to severe in Lewy body?
That's a good question. I should know this number, given that that's part of the research in our program. But with when you start with dementia with Lewy bodies, so when you start with the dementia component and you start with the mild cognitive impairment, I think the progression is quite rapid. I think it's anywhere between 3 and 5 years, and I may be wrong with the numbers, but it's definitely rapid. But then when you start with Parkinson's disease and don't present with mild cognitive impairment, I think then it's a little bit longer. Yeah. So when you start with dementia with Lewy bodies, it's a little bit different from when you start with Parkinson's disease and then you progress to mild cognitive impairment, then you progress to the dementia. There's definitely a difference between the progression. I don't want to comment on the numbers without knowing the exact rate, but it is part of it's definitely part of the research that we're doing as well.
Yeah, and talking about your research, I know you are working with Emerald Lewy and well, I'm fascinated by the type of research that you good people are doing, mainly for one reason, because you seem to have brought people that are living with a Lewy body type of dementia with Lewy bodies to contribute to research and be able to be part of the research, which is something new for me. And being able to see people with lived experience be able to contribute to research has been something that is fascinating. So maybe my question is, why that approach? Why did you decide to bring in people with lived experience?
It's a great question and something that I'm very passionate about. I think when I started in Trinity almost seven years ago now, I think one of the first sort of terms that I heard was PPI. And Professor Irsi Mulleroy, who's the PI of Emerald Lewy and also the site director of GBHI in Trinity, she was one of the first people who I heard talking about this term PPI, or patient public involvement, or it's also called PPV, patient public voice. And I think in the UK, they have a much nicer term for it called experts by experience.
Nice.
Yeah, EPE.
Yeah, that sounds good.
Yeah, experts by experience is what they call it there. And the idea being that, that research and academia is perceived to be this sort of ivory tower kind of a thing. And people speak in these very fancy terms and they don't know what they're doing. I mean, they know what they're doing, but we as commoners don't, or not commoners, but non-scientific. You see that's the kind of term that's being used, right? That we're commoners and they're elite, and there's all of these power dynamics that happens, that is present in our society between academics and non-academics. And so one of sort of the goals of PPI or PPV or EPE, like experts by experience, is to build that bridge between the academic world and the world outside, and to really sort of reduce the jargon and talk about science and do science with the people rather than for the people or to the people. Because a lot of people, especially, I mean, in countries where we're coming from, we see researchers who go into the community, they collect data, the ethics is so, or at least it's a little bit sketchy, or at least you don't know enough to even ask questions. And there's this, oh my God, they're coming from this institution and it has all of these rankings and it's one of the best institutions in the world, or it's coming from a foreign institution, oh, we can't ask these questions. And there's all this red tape and this sense of elitism about it. And the whole idea was to break that. And I was drawn to that idea of PPI and doing research with the people rather than for the people. Also, personally, PPI also makes life a lot easier for researchers, because, I mean, of course, we're talking about with researchers who, just want to collect the data for the data and look at people as numbers. It's not just them we are talking about. Even, I mean, researchers who are very ethically grounded, who drive and who do value-based research, we know that research takes time, to get an ethical approval. Even for a simple study, depending upon which committee you go to, can take up to like 5 or 6 months. And almost initially you're contacted and then you don't hear about it. And even after that, if there needs to be a amendment that's placed, that takes time. And especially if it's something related to, if it's a drug related study, or if it's a randomized control trial, that's going to take ethical approval. It takes a while as well. So the idea is to bring in the people to witness what happens in research and to be part of it. And especially when we're building the study, it's also to reduce research waste. Because, I mean, we understand our research questions are derived from the literature. But what is the priority on the ground is a different sort of, it's a different ball game. To study Lewy body dementia and to live with Lewy body dementia. It's two different things. And there's so many, as a family member, as a carer, or a person living with, there's so many things that we don't understand. It's as simple as, using a large font, or not using certain colors, or, or maybe not using an iPad, or instead of using an iPad, you use a laptop or you use a bigger desktop. Because one of the things that happens with Lewy body dementia is that people don't have visual spatial information. They lack visual spatial information. And so it's also about designing an environment that is conducive to them and they feel comfortable in. It's instead of, if you're bringing in somebody to, either collect bloods or collect EEG, then you want to make sure that your environment and your room is, it doesn't have it's not a trip hazard. No, it's something very simple. It's just, it's something that you don't think about as a researcher. But when you bring in a person and you ask them, okay, what, if you were the person who's being tested, do you like the space? Do you want to change something here? And, and I know space is a big constraint, but it's even, just dim the light a little bit or raise the curtain a little bit. It's things like that. And so from things like that to reading your participation information leaflet, and it may make sense to you as a researcher, but somebody who's reading it might not even understand. You might have terms there which is very research focused. So it's really about building that relationship.
But how do you make sure, because I know from a researcher perspective, you're coming in without any emotions attached to the study, for example, and you have people that have got lived experience. They experience so many things outside that affect them. It could be, I don't know what type of problems, right? Then don't they bring in a particular bias to your study? And if they do, how do you try to remove that bias? Because I think
I see what you mean, but I think for me, I think the problem is that we don't bring in emotions. And I think the bias that we're talking about here is just compassion. When you remove emotions from anything, I think it's the same kind of discussion that people have in the medical field. That as a surgeon, do you feel compassionate towards your patient? Do you have emotions towards your patient? It's the same kind of conversation.
Yeah.
So being objective does not mean being emotionless. So there's a certain level of intelligence that emotion brings, and a certain level of sophistication and trust that emotion brings to a particular research study. And I think we really underestimate that. And that is the emotion that is going to build trust in the community, that is going to bring your people back and actually have them interested and motivated to be a part of this research, because they understand that it is not being done to them. But, as much as, if you think about this logically, you need these people. You can't do research without the people. And, and what is the best way to get, why are you doing this research? It really, emotions to me challenge you to think beyond what you are, or not you as in what we are used to and what we're trained. And I think, and this is a much larger discussion, and in my opinion and my approach to even education as such is to involve emotions, because emotions are, even from a neuroscience perspective and from a systems perspective, emotions are really important to weed out, and they're a very efficient mechanism when used correctly to weed out what is important, what is priority, and what is not. I think we sort of confuse the terms being emotional and being emotionally dysregulated is what is a problem. But when we are able to regulate our emotions, and when we're able to read our emotions and the other person's, I think we do good research. Two, we do a lot of good for the team. And that's really what brings the team together. When we're talking about interdisciplinary teams together, that's really what brings them together.
Yeah, it's interesting having attended some of the seminars, because I have seen the people with lived experience get excited to contribute, and also it gives them a sense of purpose, because then they feel they are contributing to research, other than just hoping that a scientist is just hoping that you could one day decide to donate your brain to research after you pass. I think they feel happy that they are part of the research. And in most cases, we love talking in the hospital setting. We love talking about people-centered care, but there's no people-centered research.
Yeah.
When I looked at the type of research that you're doing, the people that you're working with, I was like, oh, that's people-centered research right there, and that's what's so fascinating to me. So, I guess, to any research that challenges, is there a challenge maybe to this type of research that you think it's a very good opportunity to explore? And like, is there like a particular challenge with having people with lived experience in your study that you feel you're experiencing, and because every challenge is an opportunity?
Yeah, I think I see. For me, I think the challenges are, one, to make sure that they're not overworked as well, because we have to be sensitive that these are people, either if it's the person with the condition or if it's the family, especially with dementia, that there may be they have to, if it's a care partner, then they have to make arrangements and they have to make room, they have to make sure that their partner is taken care of, or if they have to bring the partner along, then you have to kind of be sensitive to when we start meetings. Are we doing this online? Are we doing this in person? How is their time compensated? Are they having respite? Let's say you have a panel of 8 people. Does everybody need to be there, or just a few people are there? And is there usually, so we work with a chair and a co-chair, and they are the point of contact between the research team and the PPI, the lived experience team as such. Don't bring all of them every time inside as well. So we have, and I think that trusted relationship between the researcher and the chair and the team is really important. so that the team feels that the chair is doing that role of bridging the research team and us, basically. And I think we also need to really think about, especially when we're doing patient-centered research, a person-centered research, and I think we really need to think about how to compensate for their time, how to compensate for their travel. And these are things that we need to write into the grant and into the budget itself. And those are the things that is essential from a very operation standpoint to think about it. Honestly, I think to add to what you said, Grant, it's not just that the people with lived experience feel, they feel motivated and have the sense of purpose, but it also keeps us accountable as well. And it also keeps us, because sometimes things change and ideas shift. And then I think it's important to involve them and see how if there are shift in ideas and if there are shift in the research itself, then what does this mean for the wider population as well? So it's important to, there will be conflicts, and like any relationship, there will be conflicts. But I think it's necessary to establish a level of trust on which then you can have conflicts. And it's like anything. It's like you and me having, if we are having an argument about a certain result in a certain paper, and that are we going to go this way or this way? And it is important to understand that they understand the science. And once they understand the science, and once they understand why it is, why things change and why, plans change, or if there are any changes, then it is important to have that conversation. And from your end, present the arguments that could convince them, and they'll come with counter arguments. And it's like anything else. And I think it is important in a very subconscious level. It is important for us researchers to acknowledge and admit that they are experts in a different sense. You are experts too. It doesn't make researchers any less of an expert. And they understand that too. That we are coming from it's us versus the problem. And we bring these different perspectives. And it's important to acknowledge that they bring a set of skills that we, without that lived experience, will not have. And they also understand that. And it's not just researchers, it's also PBI responsibility to understand. And when we talk about roles and responsibilities, that yes, researchers bring a certain level of skills, and they bring a certain level of understanding of the science that we have to respect. And we have to bring the same level of our responsibility that, okay, lived experience team possess a certain level of skills and understanding that we don't. And that's where, and we become a very complementary team. And honestly, in my experience, the lived experience team, we always talk about them within the context of the condition. Honestly, I have worked with the team outside of the context of the condition as well, because they have a life outside of that. So they have either retired from that life or they are still pursuing that life, especially if these are people who are much younger, who are middle-aged, they're still in that life. So, for example, one of the things that we have had is when we had to bring our Emerald Lewy program to schools, one of our PPI experts was a principal for about 30 years, school principal for about 30 years. So they know exactly how to deal and how to approach this group. One of them is in a hospital right now, and they work with students as well. So it's not just about the condition itself. And so it expands outside of these roles as well. And they take their own sort of organic relationship and organic roles as well. So it's quite fascinating that somehow it kind of always works out for the best.
It's amazing when you look at it, and it gives me a question then to ask: is there, when you look at the studies that you've done, the work that you've done with the people with lived experience so far, is there anything that you think they find challenging on their end, based on your current studies?
This is a good question. I think we should ask them. They've been very nice to us in saying that, oh, no, this is great. But because we should have that.
I feel one of them might be feeling overwhelmed, because sometimes you're listening to this science stuff, and
see, I think that's
your brain is trying to process. So I think
that is a very, very plausible challenge. And I think I have to ask them what we've not had this discussion. So thank you for actually for challenging me and asking me this, because whenever I've had a chat with them, they said, "Oh no, we're very happy. This is great. This is great." And it's always good stuff. But I have to sit them down and ask them, please tell us what can change it, what can improve, and where can we support you better? Are there challenges here, and what kinds of challenges? But in terms of understanding the science and being overwhelmed with the science, we've been very intentional about presenting results and presenting our research priorities in understandable, non-scientific language. Not understandable, but non-scientific language. And this is something we worked as a group with. And I think in these long meetings, they do find it quite challenging when they have to be here. I think you were there in one of these things, Grant, that, it's they don't want to leave, but some of them have, and they feel quite comfortable as well. If they say no, they've said, "No, Anusha, I think it's time, and, I think we should leave." But most of them have just stayed on and sort of being, receptive to all those presentations as well. I think that would have been one of the, I think long presentations don't work. Definitely have food and water, and start later, have respite. Those would be the kinds of challenges. But being overwhelmed with graphs and figures, we've not done that. We've very intentionally not done that. So we've presented results in very different ways, very pictorially, very, very, contextually, and from an impact side of things, rather than hit them with numbers and graphs and figures.
Nice. So as we conclude, do you know that you are the only scientist that I know, neuroscientist, that dances?
Hey, that's not true. That's not true. There's a whole lot of us. There's a whole lot of us.
I know people that dance, but they're not neuroscientists.
I know neuroscientists who's also a dancer. So I'm not the only people. I know I'm not the only person, but there are other people who do that too. Yeah.
And I'm sad that I missed the first dance workshop you had.
Yeah.
So I'm hoping there's something sooner that I could join. So why dance? Because I know you've applied most of your dance, at least in the few, I don't know, months, years, in brain health. I don't know, like quite advocacy, but why choose dance as part of the literacy?
Dance. Well, I think it's part of who I am. As much as I'm fascinated and enriched and nourished by the sciences, dance is the other side of me. I started dancing when I was 8, and I trained professionally for 12 years, Bharatanatyam, which is an Indian classical form of dance. And for those 12 years, I was performing on a regular basis. I was touring in India. So it was a very significant part of my life and quite a significant part of my professional life at the time as well. So life happened and other things took over, and I was doing my PhD and postdoc, and, sometimes these things kind of take a back seat. But no, I think some of the, I wouldn't say worst years of my life, less fulfilling years of my life have been the years that I've not danced. So it was very intentional to reintegrate with dance. And for me, dance has not always been just about dancing. Of course, there's the self-expression, there's the artistic expression, there's the arts part of it. But I was, as a child, when I was about 10 or 12, there was a workshop where each of us had to choreograph something, and it was some 1 or 2 day workshop. And at the end, we had to choreograph something based on what we learned. And I had done a piece on the germination of a seed through dance. So it was one of my sort of first explorations into literacy, science literacy through the arts. And that has always been my sweet spot, is to be between the intersection. And education is the third piece that I am very, very passionate about. I think education is a tool that's the tool that does empower us. Learning how to learn is probably the best gift that anybody can be given. Dance is one way, it's one form. It's always been dance and movement, theater, whether it's theater or whether it's creative movement, it's been movement. And dance for me is one of the ways, at least that's the way I communicate. And is one of the ways, and as part of several arts as well. Arts in general can break the barrier, can make things fun, and people don't perceive it to be a very serious class. Once we start moving, things get silly. And even from a science perspective, it sort of fires up your emotional centers, which once they're active, become key in learning and grasping, and even storing in memory. We know that emotional centers are involved, and whether you do it through neuromodulation, which is electrical magnetic stimulation, or through the arts, firing up the emotional centers becomes key to learning. And so that's kind of coming back to our conversation about why keeping those centers involved is important, whether you do research, whether you learn, whatever you do. So they're those very reliable, efficient indicators to what is priority.
Thank you so much for sharing your life work with us.
Thank you, Grant. It's been a pleasure.
So I'm going to share the link to your bio in the description. So to everyone, if you enjoyed this episode, please subscribe, like, and share. Thank you.
Thank you, Grant.